Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Good morning, afternoon, evening, however you decided to open up this vaulted presentation. This is the mammography topic of Mammography Quality Standards Act, or MQSA if you want to sound cool at dinner parties, but don't worry. We're going to break this down so it's informative, digestible, and trying to be somewhat funny. But funny and federal regulation in the same sentence doesn't always work. As per usual, disclosures, I have none. No shady backdoor mammography deals, or no free compression paddles or contrast swag. So, just to start, what is the Mammography Quality Standards Act? Besides being a mouthful, we shortened it to MQSA. This act was passed in 1992. Why? Because back in the 80s and early 90s, mammography was basically the Wild West. There were no uniform standards for equipment, for technologists, or the people reading them. A person could get a mammogram at one clinic and then another down the street and get completely wildly different results, like flipping a coin, but yet with your life. The FDA had conducted studies and found that a significant percentage, up to 30%, of mammograms were of poor quality, which is horrifying. So Congress stepped in and said, enough, let's fix this. That's how the MQSA was born, to standardize image quality, reporting, facility accreditation, and personal qualifications. So the bottom line, MQSA exists to ensure that every single woman or person in this country receives high quality, reliable mammograms no matter where they live. So now that we've got the backstory, here's how MQSA touches every corner of the mammography process. It governs the radiologists, the interpreters of these sacred images. It governs reports. Every line and label must be just right. Images got to be crisp, clean, and labeled with appropriate positioning and technique. Facilities are reviewed from dusty screens to phantom testing, and everything must pass muster. MQSA is like Santa Claus. It sees everything. If you're not compliant, you're going to get more than a lump of coal. You could end up in jail. That's a whole nother story. So, what are the initial MQSA qualifications for a radiologist or interpreting physician? So, if you want to read the mammograms, let's start with this checklist. You need a state license. You must complete 60 documented hours of education focused on mammography or breast imaging. And you must interpret at least 244 mammograms in a 6-month period during the last 2 years of your diagnostic residency. This also includes, in your residency, a 3-month block of formal training, and it has to include everything such as physics, dose, positioning, and of course, your new best friend, your MQSA. How does an interpreting radiologist continue certification? Well, we have to read 960 mammograms in the past 24 months. This is not optional. We want you to be fresh MQSA, and the federal government wants you to be experienced consistently and constantly. You must have 15 CME credits in mammography during the last 36 months, because lifelong learning never ends. So think of this as a gym membership for your mammography brain. If you stop training, you lose your gains and your ability to read them. Well, what if they introduce a new mammographic modality like digital mammography in the early 2000s or tomosynthesis? Well, if there is a new modality, you have to have 8 hours of formal training before you can interpret officially a new mammographic modality independently. But here's the plot twist. This does not apply to ultrasound, MRI, nuclear medicine, or procedures like cyst aspirations, etc. You would have to include accreditation if you wanted to be accredited in ultrasound. For instance, there are certain certifications for ultrasound by the ACR, the American College of Radiology, if you wanted certification in ultrasound. So let's talk reports. MQSA doesn't want just any report. It wants detailed, timely, and clear reports. You need the name and location. You need a final assessment in BI-RADS, numbers or terms. I know that there is another talk that specifically discusses BI-RADS. Now, as of 9/2024, and even before that in some of the other states, it's mandated that you must report the density of each patient in a patient-friendly terminology. For instance, if a patient has dense breasts, their letter may include the fact that they have dense breasts, and they may want to consult with their physician clinician in regards to additional screening. However, the state or federal governments have not mandated insurance companies to pay for any additional imaging based on the density. So communication, if we have a final BI-RADS conclusion of suspicious or highly suggestive, those are BI-RADS 4 or BI-RADS 5, we have 7 calendar days to notify either the ordering physician or patient with these results. We are required to notify a patient of their screening results regardless of the BI-RADS, benign, negative, or incomplete, within 30 calendar days of imaging. If a patient has an incomplete, which means we are recommending additional imaging and we'd like the patient to come back, then we have to notify them within the 30 days. However, from the day that we call that study incomplete, we have 30 calendar days from that initial report to create an addendum or report indicating why a patient did not return after 30 days. So all images must be labeled, and these labels must be permanent. So they need their name, they need some sort of identifier, which could be the medical record number, patient's social security number, although we don't want that one, and less likely or less used is the date of birth. We have to have the date of exam, the view, either cranial caudal, denoted CC, or mediolateral oblique, and we have to have the laterality labeled. We also need the facility name, location, as detailed as putting city, state, and zip code on there. We need to have a tech ID. And why is that important? Well, sometimes if you want additional views, or if the positioning is not correct, it's nice to know which tech that performed the study so we can talk to them and discuss different improvements. It's also very important to label what cassette was used in the acquisition of that image and what mammography unit, because the cassette could be broken and we need to identify that cassette, or a mammography unit may be demonstrating some problems and it is important to identify which unit it is. Even our images, and not only our images, but we also have to have facility compliance. All personnel have to keep up current accreditation and certification. And we say personnel, we are including not just the interpreting radiologist, but our technologists who are acquiring the images and our medical physicists who test all of our equipment on a regular basis. There are ongoing medical outcome audits. And like I had said before, as of September 2024, the federal government mandated that breast density is to be reported and communicated to the patients. A lot of times people will say, well, since you have a standard for mammography or tomosynthesis, what about stereotactic or tomosynthesis guided biopsies? And the answer to that is it's not necessarily under the MQSA Act. However, it is a state-specific certification. So our state says Michigan requires ACR, the American College of Radiology certification, which is a whole process and application which we submit to the ACR, and that is evaluated annually. We have to make sure it's an MQSA certified provider. And to start biopsying, we do want to have at least 12 supervised biopsies before you can start doing these on your own independently. And to keep up this certification, it's important to do at least 9 out of 36 image-guided procedures in the previous 36 months. So they'll look back every 3 years to just make sure that if you are doing procedures, 9 out of 36 might be stereotactic guided or tomosynthesis guided for you to remain certified. Sometimes this question will show up on board exams, wink, wink. But what are some of the QA testing and what is the timing of these testings? For instance, daily, we need to clean the monitors everywhere. Makes sense, we don't want dirty monitors. Weekly is a lot more. Typically on Mondays, every week, we must run what we call a flat field test. You have this test performed on all units before all others. And what that is looking at brightness, making sure that it's uniform. We're looking at the high frequency modulation. We're looking at the signal to noise ratio. We're looking for a bad region of interest or trying to see if there's any bad pixelation. What happens after we perform this test, we'll get either a pass or a fail. This test, even though it does test for a lot of heavy physics weighted elements, it is a fairly straightforward cassette test in which the tech will place the cassette and hit the button on the machine, which will say pass or fail. If it's passed, then we get to move on to the phantom weekly test. If the test fails, then we immediately call our physicist and engineers to evaluate the unit that's failing the flat field test. After a successful FFT, then we can do our phantom test. The phantom test's just making sure that our images are consistently good and that we can identify the appropriate resolution and that we have adequate and consistent quality images. Other weekly tests is a contrast to noise ratio, CNR, and our modular transfer function. If again that fails, we call our engineer and we call our physicist. Once a test fails, the units cannot be used until they undergo appropriate corrections, and we move back all the way to the very first flat field test to start retesting. Now, our contrast to noise ratio is considered adequate over the 0 to 51 line pairs per millimeter spatial frequency, which is arranged by obtaining an estimate of MTF values at 2 and 4 line pair per millimeter. And every single monitor display undergoes a QC. Even our at-home monitors will undergo a QC for us to be able to adequately and officially interpret mammography. Once a year, it's time for the grand annual inspection. One thing, easy, check lead aprons for defects. We don't use lead aprons very often in mammography, but even though we do use them, we do have to check them for any defects. But also annually comes the inspections, which includes reviewing all the documentation of the above so tests, and every facility. So for instance, the University of Michigan has several facilities at several different locations. Every location is considered its own facility and needs to undergo its own inspection. All inspections include all the above documentation, and it also involves medical outcomes for not just the facility, but the individual interpreting radiologist, which includes our positive predictive value, how often is it a cancer when we're recommending biopsy. We also are looking at our cancer detection rate and how does this compare to the national rate. And we're also looking at our recall rate, our percentage of how many times after a screening mammogram do we call a patient back for additional imaging. So in conclusion, this is a very brief and generalized explanation of what the Mammography Quality Standards Act involves, and it's complicated, it's detailed, and it's quite demanding. It is the most federally regulated area in all of imaging throughout medicine, next to our nuclear medicine areas. But this ensures consistency, quality, and accountability, because breast cancer screening, it should never be a gamble. So complicated, definitely. Rewarding, absolutely. So thank you. If you have any suggested revisions or any noticeable discrepancies, please feel free to email me.